clinical research portfolio for Medtronic Defibrillation Solutions. I want to thank all of you for joining our session today. Welcome. We have a very distinguished lineup of faculty for today's discussion, all of whom have served as investigators in the LEADER clinical trial evaluating the Ominisecure lead. Dr. George Crossley serves as the trial lead and is an electrophysiologist at Vanderbilt University in Nashville, Tennessee. Dr. Pamela Mason is an electrophysiologist at the University of Virginia in Charlottesville, and Professor Prash Sanders is an electrophysiologist at the University of Adelaide in Australia, where I think it's currently almost lunchtime on Friday. A big thanks to all three of you for leading us through today's discussion and for your involvement in the clinical and research activities related to Ominisecure. Let's take a quick look at the agenda. Dr. Crossley will start us off with a brief overview of the Ominisecure lead. Then Dr. Mason will walk us through the design of the LEADER clinical trial and its results, which have been presented at worldwide congresses and published in Heart Rhythm. After that, Dr. Crossley will present the reliability work that has been performed to evaluate the 10-year projected reliability of the Ominisecure lead. And then Professor Sanders will do a deep dive on the sensing and programming results from the clinical experience. And after each section, I may pause and ask a question of each presenter. And then once everyone has presented, we'll take questions from all of you in attendance. So please be jotting down your questions as we go. Now, before I hand it over to Dr. Crossley, there are a few disclosures to share. As mentioned previously, the Ominisecure lead is investigational. As such, any inquiries you have that are outside the scope of our presentation today should, of course, go to the Office of Medical Affairs. And then on the next slide are the disclosures for our physician presenters. So now, without further ado, let me invite Dr. Crossley to share with you an introduction to the Ominisecure lead. Dr. Crossley?
Thank you, Amy. It's my pleasure to be here, and this has been a wonderful journey. Why are we even studying this lead? Why do we need a new lead? And the reasons are here in that ICD patients and cardiac resynchronization therapy patients certainly live longer today than they did when we all started putting in defibrillators years ago. We also understand the cost and consequences of complications better than we did in the past, and the lead recalls have taught us that lesson. So what do we want out of a lead? We want a lead that has flexibility and ease of use, and that'll go where we want it and stay where we want it. We want the lead to be highly functional and highly reliable. We think we want smaller leads, and I think a lot of anecdotal data would point us in the direction of thinking that smaller leads will have better outcomes. And of course, our aspirational goal is to have leads that last even longer than the leads that we're using now, such as the Quattro lead, which has remarkable longevity and durability. ICD patients typically can live 20 years now. And the tricuspid regurgitation rate with ICD leads is higher than it is with pacemaker leads, and is about 3% even at the short follow-up of 2.5 years. And it's much more as the lead matures over time. Our lead survival rate at 19 years now for the Sprint Quattro lead is about 88%, which is great, but we can do better. And the average hospital cost to treat a lead failure is significant at over $20,000. So this shows the Ominisecure lead on the left, the 3830 Select Secure lead on which this is built in the middle, and our Sprint Quattro lead that we're also familiar with on the right. The difference between the unique feature of the Ominisecure lead and the 3830 lead is the cable-based interconductor. And that gives it great flexibility and great resistance to fracture, and keeps us from having one of the most common fracture mechanisms, which is collapsing of that inner lumen, creating a fold in the metal, which sets up for a conductor failure long term. The Ominisecure lead's a bit different than the 3830, and that it has the same inner insulate, 2 layers of inner insulation there that we have in the 3830. The outer conductor and the outer insulator is a bit more robust because it's not only for sensing, but it's also for defibrillation energy. And the outer insulator is a bit thicker. We can see here the Sprint Quattro lead that we're all used to, and how these leads are in contradistinction to that. I will remind you that the 3830 lead is often thought of as being a new lead, but for conduction system pacing, it's actually been marketed since the early 2000s and has a really remarkable longevity in the product performance report. Thanks, Amy.
Thank you so much for that introduction, Dr. Crossley. I will now turn it over to our second presenter, Dr. Mason.
Thank you so much. So it is my great pleasure to present the pivotal trial results from the LEADER trial studying the Ominisecure lead. So the LEADER trial was a prospective, multi-center, single-arm, non-randomized pivotal trial. And this truly was a global trial. There were 45 sites in 17 countries. For this study, the lead was implanted in standard RV locations. So importantly, for this study, the lead was not implanted in the left bundle branch area location. There was also global physician oversight. So patients could be included in this study if they had an indication for a de novo primary or secondary prevention, ICD or CRTD. Patients were excluded if they had class 4 heart failure. And the primary efficacy endpoint was defibrillation testing at implant in at least the first 95 patients. The primary safety endpoint was freedom from lead-related major complications at 6 months. And then there was a secondary safety endpoint that incorporated a simulated patient model. So this shows the patient flow. So initially, 675 patients were enrolled. 18 were immediately exited for a variety of reasons, including being found to not truly meet eligibility criteria or physician discretion. So 657 underwent an implant attempt. 14 were exited, 13 due to an unsuccessful procedure, and 1 due to the physician decision. Ultimately, 643 patients were successfully implanted. 612 were able to complete the 3-month follow-up visit. 591 completed the 6-month visit, and then 505 completed the 12-month follow-up visit. If we look at the patient characteristics, the average age was around 62 years. 74% of the patients were male. The average BMI was 28.5, and the average ejection fraction was around 35%. Importantly, about 67.8% of the patients had a primary prevention indication. So there were a significant number of patients included in this trial that were actually secondary prevention. 82% had a cardiomyopathy, and 26% had atrial fibrillation. So for the Ominisecure lead implants, 97.9% of the patients had a successful implant. So that was 643 of the 657 patients. When they queried the physician, they found that in 99.5% of lead placement cases, the physician was able to get the lead to their desired location. In the vast majority of these cases, it was a septal location, particularly mid and low septum. So this is showing sort of a high-level look at the results. When we look at the primary efficacy endpoint, 97.5% of patients did defibrillate successfully at implant, and that exceeded the performance goal. When we look at the safety endpoint, 97.1% of patients had freedom from lead-related major complications at 6 months, also exceeding the performance goal. There were absolutely no lead fractures during the 12 months of follow-up for these patients, and when they followed the electrical parameters, they were all stable throughout the entire follow-up period. Here we're looking in a little bit more detail at these endpoints. So this is looking at the defibrillation efficacy at implant. Again, 97.5% of patients had successful defibrillation. 119 patients underwent a defibrillation attempt, and 116 of them had successful defibrillation. If you look at the figure, it shows how this was defined. In 96 patients, they were defined as having a successful defibrillation because they converted with a single 18-joule shock. 20 additional patients were viewed as having defibrillation efficacy because they terminated their arrhythmia with 2 successive 25-joule shocks in 2 separate episodes. And so the primary objective passed with 94 of 97 first consecutive patients having successful defibrillation. Again, this exceeded the performance goal. So there was 97.1% freedom from lead-related major complications at 6 months. The figure shows the timeline of those the complications that occurred, also shows what those complications were. So the majority were lead dislodgements. 11 patients had a lead dislodgement, 4 had P-wave oversensing, 2 had a cardiac perforation, 1 had a device capture issue, and there was 1 patient in this study that was a twiddler. If you look at the figure, you can see that the majority of these complications occurred shortly after implant. And in fact, after 6 months, there were no further lead-related major complications. In addition, there were no deaths related to the Ominisecure lead and no complications associated with the tricuspid valve. So again, there were no lead fractures throughout the entire follow-up period. There was a simulated patient model, and Dr. Crossley is going to be talking more about this in the next section. But essentially what they did was they took real-world imaging to create models to simulate real-world conditions. And that was combined with the clinical trial data. And the ultimate combined clinical and simulated 12-month fracture-free survival estimate was 99.97%. These figures are showing the electricals, and you can see they're very stable throughout the entire follow-up period. The pacing capture threshold is at the top. At implant, the capture threshold was very low, on average 0.6, and it stayed at that level throughout the follow-up period. R-wave amplitude sensing was excellent at implant and again remained stable. Pacing impedance, there was a small drop after the immediately after implant, but then remained stable and within desired parameters throughout the follow-up period. A number of patients did receive therapy during the follow-up period. So 11.8% of patients received appropriate therapy for VT or VF throughout the device follow-up. There were 100 episodes where patients received a shock, and 95% of them were successful. If we break down the 5 episodes, which occurred in 4 patients that were not successful, in one case, the rhythm self-terminated. 3 were occurring during a VT storm. There was 1 patient who failed to successfully defibrillate and did pass away, and ultimately this patient was found to have amyloidosis. There were 479 ATP episodes that occurred, and 359 of them were successful in terminating the arrhythmia. So that was a success rate for the ATP of 74.9%. Inappropriate shock rates at 12 months were comparable to what's been described for other leads. There was a 2.7% inappropriate shock rate for single chamber devices, a 2.8% inappropriate shock rate for dual chamber devices, and there were no inappropriate shocks due to P-wave oversensing. So in conclusion, the LEADER trial studying the Ominisecure lead met its safety and efficacy endpoints. There was high defibrillation efficacy at implant at 97.5%. There were low complications through 12 months. There was a 97.1% lead-related complication-free rate. There were no fractures, and the electricals were stable throughout the follow-up period, and there was a very low inappropriate shock rate at 12 months. The LEADER trial follow-up is ongoing. We are planning for a long-term prospective post-marketing study as well. And then there is a dedicated study of the Ominisecure lead in the left bundle branch area location. That study has been initiated and is ongoing.
Thank you for that summary of the LEADER clinical trial experience, Dr. Mason. As you mentioned in your talk, the lead-related complication-free rate met and exceeded the pre-specified safety endpoint. And the most prevalent complication that you noted toward that endpoint was actually around lead dislodgement. Can you say more about that, and can that be addressed with attention to technique, for example?
Yeah, so it is important to note that this lead is not implanted with a stylet. It is a solid lead, as Dr. Crosley described. And so it's implanted using a sheath. For people who have lots of experience doing left bundle area or his bundle pacing, they may have experience using sheaths, but there were implanters in the study who this was a newer technique for. It's not super difficult, but it is slightly different than what most people are used to. So I think with good training and planning and good technique, these can very easily be successfully implanted.
Thank you so much for your insights, Dr. Mason. I will now invite back Dr. Crossley to present on the 10-year projected reliability from the modeling experience of the Ominisecure lead. Dr. Crossley?
Well, thank you, Amy. So I think the modeling data in this trial is probably the most important part of the data that we collected. I mean, the clinical trial was great, but as with all the things we use in cardiology, doing a 6-month, 1-year, 2-year trial gives us useful data on functionality. But what we really want to know is how well this thing's going to last at 10 years or maybe longer than that. And so what we did is use some techniques that have been done for a very long time, where bench stress testing of the lead is used at higher rates than normal bending and look for failure. In the past, that was done with the bending angle and the frequency determined by the engineers that were building the model, and not really based on patient data. And what we did in the Fidelis follow-up study was to try to generate a model that would predict failure ahead of time and not wait for it to hit our patients. And in this model, we took the lead, put it in patients, and studied it, as we can see here on the left, where we would image it in a 3-dimensional way, look at the lead in the pocket, look at the lead in the shoulder and the intravascular area, and then look at the lead in the cardiac area, and look for bending and stressing and determine those angles. And then we would look, when we have other sets of data that tell us the frequency of shoulder motions at various ages, and then we obviously know the frequency of cardiac motion by the heart rate. And so we would put all this into these models. We would test it at nominal at the bend ratios that we observed, and then we'd test it even more aggressively at higher frequencies and sharper bends. And we generate a statistical model of this where we test the lead to failure, where we try to keep it on the machine until it fails. We had a bit of a problem with both the 3830 and the Ominisecure getting it to fail and getting it to fracture because it's so resistant to fracture. This shows a figure from our paper that was looked at the way we built a model to analyze the Fidelis fractures. And this is the most important graph, where it shows the frequency of failure using the model as opposed to the frequency of failure seen in the field, where these were carefully looked at and carefully reported. And we can see here that we have the Quattro results in the 2 different models of the Fidelis, and we looked at it both in the intravascular region and in the shoulder region. And you can see it's a 1-to-1 correlation. And that is that the modeling data accurately predicted the field data. And had we had this model, then Fidelis probably never would have been released, and the problems would have been noted during the clinical trial. These show images of how we went about this, and these are the demographic data for this subset of our Ominisecure patients, and it's very similar to the data that Pam presented with height, weight, and gender all being comparable to the whole population. We see here in the upper right a running loop of the cardiac region. We can see the Ominisecure lead here colored in red, so you can see it, and you can see the bending there caused by the tricuspid, the motion at the cardiac fixation point, and the same thing in other projections. And we put this all into the model and create a three-dimensional model with it. One of the things that was most surprising when we did the Fidelis analysis is the shoulder motion. None of us had any idea that the leads move that much in the shoulder and pinched and bend and twisted the way they do. Typically, when I show these pictures to electrophysiologists, I can hear the audible gasp. I can't hear them since you guys are all on mute right now. But you can see here that there's dramatic bending in the pocket region, and then we have good data from other studies that show us how often patients move their arm in manners like this for various ages. We take that back to the benchtop model, and we have machines, multiple machines, that create this bending and twisting and other motions of the lead. And then we exaggerate that, and then we speed it up so we can get a 10-year model. It took us about a year to get the data for the 10-year model. And we look at that. We looked at it in the intracardiac region, in the vasculature, and we also looked at the connector to look at stresses there. We submitted all this to what's called a Monte Carlo statistical modeling, and so it simulated about 50 million patients. And using these data, we could, with good confidence, say that the Ominisecure lead would have really good 10-year survival. And Pam showed you some of the data, but here's the data from just the modeling that shows the 10-year survival is 98.2% for this. It was a bit lower for the Sprint Quattro and a lot lower for the Sprint Fidelis. So again, I think this is honestly the most important part of the data from this study. We also had data from time and motion data from adolescents. And so we could use that in the model to try to predict how this lead might work in adolescent patients. The Ominisecure study, the leader study, as we called it, did not have any adolescent patients in it, but the modeling data gives us a good model of it and shows us that we would have a good predicted longevity of the adolescent patients at 97.9%. where the adults were 98.3%. So in conclusion, the LEADER clinical trial showed high defibrillation efficacy and low complications and no clinical fractures through 1 year of follow-up. Consistent with the trial, the modeling projects a really durable 10-year fracture-free survival rate. And the high lead durability rate is also projected to be quite good in the adolescent population, though we didn't clinically study it. This same approach is being utilized now in the LEADER left bundle study, where we're putting this lead into the left bundle area for pacing. And information on that trial can be seen at clinicaltrials.gov, and that's the number of the trial. Thank you, Amy.
Thanks so much. Thank you, Dr. Crossley, for that presentation. As you noted in your talk, the modeling work was conducted on both an adult and an adolescent group. You also mentioned that adolescent patients were not included in the LEADER clinical trial. But what can you tell us about the inclusion criteria related to age for the LEADER LBBAP study that has more recently gotten underway?
So that trial is underway, and we're recruiting for it. And it does allow, in addition to the adult patients, it allows patients 12 and up to be enrolled in the trial. And we hope we'll have a reasonable amount of data from that population. I think, the lead durability is so important for those patients because they're much more active and they're much younger, and we expect them to live a lot longer. So we look forward to having good data there.
Yes. Okay. So more data to come in the future, perhaps. Thank you very much, Dr. Crossley. And now I will turn to our final presenter, Professor Sanders, who will share with us information on sensing and programming from the LEADER clinical study. Professor Sanders?
Thank you, Amy. So one of the things that we learned in the Ominisecure lead is this is now an integrated bipolar lead. So the coil works as part of the sensing mechanism of the lead. And so we need to be cognizant of how the sensing and programming of the device is undertaken. And I want to share some of the things that we learned as part of this trial. So P-wave oversensing is obviously one of the key things that we're concerned about if we have an integrated bipolar lead. But in reality, this is a rare event. However, it may occur if the sensing component of this is very close to the tricuspid valve or within the atrium. And then you have the situation, which is shown in the figure here, where you can see atrial activity on the ventricular lead. It can sometimes fall into the VT or VF zone. It may give inappropriate detection. And if it persists long enough, potentially inappropriate therapy. One of the good things is this is something that's fairly easily mitigated by adjusting the sensitivity of the ventricular lead. And what we'd like to do is to actually take you through what was seen as part of the LEADER trial. So the first aim of this study was to look at evaluate the complications that were due to P-wave oversensing in the LEADER trial. And the second is to evaluate the additional P-wave oversensing episodes that we were alerted to that didn't result in any adverse event. Potentially, we could use EGM and recorded episodes, the R-wave trends, and the percentage pacing to try and learn when we may be having P-wave oversensing so that we can follow these patients up more cautiously. So the important thing in the LEADER trial is we had no inappropriate shocks due to P-wave oversensing, and that's kind of important. In terms of major complications that were reported as P-wave oversensing, there were 4 cases over the 12-month duration of follow-up of these patients. One of these was in a person who had a CRT device, had atrial fibrillation, and there was far-field sensing. It did cause double counting, and there was a care alert of lead integrity, really the short VV intervals, which allowed us to review the case and reprogram the sensitivities, and the patient situation was resolved. There were, however, 3 cases where they went on to have replacement to non-study leads, and I'm going to talk more about that because most of these also were managed initially with reprogramming of the sensitivity. There were no minor complications associated with P-wave oversensing. To show an example of what the oversensing looks like, or the sensing that we see traditionally on these leads, you can see here the atrial lead on the bottom row and the RV tip to coil on the top row. And you can see the far-field atrial activity, but compared to the ventricular activity, this is something that is fairly easily programmed around. In addition to what was labeled as complications, there were 12 additional episodes where there were P-wave oversensing that was not related to any adverse outcome. One of these was at the time of implantation, and it was obvious that the lead was a little bit too close to the atria, and the operator had to reposition that lead, and there was no issues after that. There were 11 further episodes that were reported, and these these programming changes were undertaken. It was after implant, and there was no ongoing issues related to that. There was no inappropriate shocks due to any of these instances. On the bottom left-hand side, the figure shows this sensing that you can appreciate. the far-field sensing of A2 activity. And if this is obviously large enough, then we can start to count that in the ventricle as it has. There's a few clues that we can use. So in the bottom right-hand figure, the sensitivity is set to 0.3. And when it's done at that, you can see occasionally you see the true R wave sensing. And then at other times you get the P wave sensing, and it may falsely reflect the last measured P wave at 0.4 here. And this is fairly easily adjusted by reducing the sensitivity of the lead, and suddenly you get the true R wave. And so this is something that could be used to in the follow-up period. Similarly, the percentage of ventricular pacing is a good indication, particularly in people who are more dependent or have CRT, where we may have less ventricular pacing. If we are looking at the and see a change, then that may be an indication to review the situation in terms of P wave oversensing. So in total, there were 16 P wave oversensing episodes that we're aware of. One of these patients, as mentioned, was reimplanted at the point of implantation. 14 of these episodes were resolved with programming changes. Now, what you will note, firstly, is that almost all of these occur within the first 3 months. And so it's an opportunity to review and program these devices up early. The second is that out of the box, the sensitivity that's set is 0.3 millivolts. And we have quite a margin that we can change this to in terms of reducing the sensitivity, which is what was done, as can be shown in these cases. Now, there were 2 cases marked here in the asterisks where changing the sensitivity actually removed the far-field sensing, but a decision was made by the operator to change the lead to a non-study lead. And then there was one patient in whom, despite the changes that were undertaken, we were unable to totally eliminate the far-field sensing. And so this lead was also changed to a non-study lead. Now, in terms of the impact of the mitigation measures that were undertaken, as mentioned, one lead was repositioned at the time of implant. This person had no further P wave oversensing. In the 12 leads that were chronically evaluated, 11 out of the 12 were the sensitivity was reduced once, and that has eliminated the P wave oversensing. In one, there was a second reprogramming that needed to occur to resolve the situation. Now, also in terms of inducibility and the sensing of the ventricular arrhythmia at the time of testing. Now, these were tested in this leader study at the least sensitive setting of 1.2 millivolts, and all but 3 patients, this was adequate in terms of the sensing. In the other 3, we had to improve the sensitivity in order to detect, but it was well above the threshold that would require reprogramming for P wave oversensing. Similarly, how did this impact in terms of clinical VT-VF episodes and the sensing of this? Now, we have 14 months follow-up. There were 505 episodes of VT-VF in 76 patients who received appropriate therapy in terms of either ATP or shock therapy. And none of these episodes showed under-detection of VT-VF. One of the things to, again, note is that the nominal setting and 91% of patients were discharged at this setting is 0.3 millivolts. And you see that a further 10% of these patients have been changed in terms of the sensitivity. And none of these had any impact in terms of VT-VF sensing during the study period. So let me conclude at this point that what the LEADER clinical trial has shown is that this is a highly effective defibrillation efficacy with low lead-related issues or complications, and certainly no fractures during the follow-up that we've had. There is a low incidence of P-wave oversensing, although this is something that we were prospectively evaluating because of the integrated bipolar lead, and there's been no inappropriate shocks as a result of this. The P-wave oversensing seems to occur early, and so it's an opportunity at implant to be able to look at this and mitigate by programming to a less sensitive setting. And these changes did not impact any VTVF detection during the follow-up period. So thank you for that. And I might actually talk about the whole study as a whole and just summarize what we've presented here today. So the first thing is that this trial shows that this lead is highly effective in terms of defibrillation. It has low study-related complications and no fractures over the duration of the study itself. Now, it is ongoing in terms of the data collection, and there is a plan for post-market release, a study of prospective registry that is planned. Consistent with the trial, we did undertake durability testing in modeling studies, and the data to date is consistent with what's been observed clinically. And this has now extended that to 10 years in terms of what we may expect seeing in this lead going forward. And this seems to be a highly durable lead. There is a low incidence of P-wave oversensing. There's been no inappropriate shocks as a result of this. And really, this is something that occurs early and can be mitigated by programming at the time of implantation. So thank you for that. And I also will highlight one of the things that we've already talked about during this presentation is that the Ominisecure lead is now being evaluated for left bundle branch area pacing. And this is done in a clinical study. It's conducting using the existing US FDA investigational device exemption for the next generation ICD lead, confirming the safety and defibrillation efficacy of placing this lead in the left bundle branch area, both in terms of ICD implantation, but also in terms of the LOT CRT patient population. As part of that study, the ICD component is being followed for at least 3 months, and the CRT subjects are being followed for 6 months with this lead. And hopefully we'll have more information about the durability and efficacy of this lead in the left bundle branch area pacing. Thank you, Amy.
Wonderful. Thank you very much, Professor Sanders. So in your talk, you shared some important information about the observed ability to program around P-wave oversensing if seen in the clinical study. So maybe a two-part question for you. How did the sensing results from the study line up with your expectations? And then what can you tell us about the importance of lead positioning at implant to help you from a sensing perspective?
So going into this study, I think all of us were wary of the fact that this was an integrated bipolar lead. And in fact, the coil is a little bit longer than what we were used to. And the possibility of P-wave oversensing, it was actually quite a surprise that it was not very common. You'd see a very small P-wave, and it was very rarely of any significance during our implantation procedure. So that was quite remarkable in terms of what I was expecting going into the study. Having said that, we probably all took a little bit of care on how to place this lead and to ensure that most of that coil is, if not all of the coil, is within the ventricle itself. So I think that's going to be important in terms of following for new implanters in positioning this lead, is to ensure that you get a position that is good for pacing, but also good to keep most of that coil into the ventricle itself. But we now have data to say, actually, test and see where you're at, and we can program even in difficult situations. So I think it fits with it's better than what we expected, because we expected more, but we have learned techniques to kind of leave the lead predominantly into the ventricle, which will help the situation, and we are able to program around it.
Wonderful. Thank you so much. And thank you all for your terrific presentations. So at this time, I'd invite the three of you to come off mute and come back on screen for our peer-to-peer discussion. And at this time, we're happy to take questions from our live audience, which you can submit via the meeting feature. And I have to say, the presentations have clearly generated a lot of interest already because the questions have been coming in even as you've been talking. So I will go to a first question from the audience here. This one is directed at the talk that you gave, Dr. Crossley, on the modeling work. So this is the question, is there something to be done with lead insertion at the subclavian vein to minimize effects of shoulder motion?
Well, I think the Fidelis data would tell us that we need to try hard not to traverse more of the pectoralis major muscle than we need to. One of the interesting things, not from this study, but from the Fidelis study, was that the more lateral we stuck, the quicker the failure rate was very similar, but the time to failure was quicker with the Fidelis if the lead traversed perpendicularly through a big chunk of the pec major muscle. And there's nothing about this study that's going to get at that. Because I don't think anybody's sticking out there anymore. There were many implanters that converted from cephalic vein implant to ultrasonic guidance and used a similar position for the ultrasonic stick as they did for the cephalic vein insertion site. And that created an earlier fracture rate with the Fidelis. I thought that was interesting and part of that study that didn't get a whole lot of attention, but was clearly demonstrated.
Wonderful. Thank you so much. Could any of you on the panel discuss a little bit about what catheters you've used in the clinical studies for implanting the Ominisecure lead?
So I'm happy to comment on that. So we were using existing sheaths that were previously available. There is the H40 guide produced by Medtronic, and I used that for a fair number of patients. I also used some inner guides as well, so basically for coronary sinus leads. But I would say it was probably 50-50 as far as the implants that I did as part of the study. So I'd be interested to hear what Dr. Crossley and Dr. Sanders were using.
Yeah, I got to say, most of our cases we use the HIS 315, and it seemed to go to where we wanted to. I guess there was only a handful where you had to manipulate significantly where you would change over, but that was our go-to sheath during this study.
And it was for us as well. We were probably 75 or 80% C315, and the rest were mainly the deflectable sheath, the 305 sheath, which is a bit longer than the C315, and that's why we honestly went to it when we had big hearts.
Okay, so as we come to the top of the hour, I would like to take a moment to thank our faculty, Dr. Crossley, Dr. Mason, and Professor Sanders, as well as all of you who are our audience. And thank you for your participation in the Global Grand Rounds